In today's episode, we'll be talking about one of the leading causes of fertility struggles, and that is PCOS. Welcome to the Finally Get Pregnant Naturally podcast, the podcast helping women identify the real reasons you haven't conceived or stayed pregnant so you and your partner can finally grow the family of your dreams. I'm your host, Dr. Katie Wood. Let's dive in, shall we? In this episode, you'll discover which advanced labs go beyond what your OB or fertility doctor typically check, the different underlying causes of PCOS, and how to reduce pregnancy risks naturally. I'll be talking with Caitlin Johnson, a registered dietitian, functional medicine practitioner, and founder of PCOS Fertility Nutrition, a thriving global brand helping women with PCOS take charge of their fertility, hormones, and health. So, welcome, Caitlin. I am
Thank you.
excited for our talk today.
Thanks, Dr. Katie. It's always fun to connect on a new podcast. I listened to a handful of your podcasts today while I was driving around just to get the vibe of the show. And I loved one thing I really appreciated was like just the episodes, you get to the point and help someone out with really applicable information, and then they get to go along their way. And
Yep.
I think that's great.
Awesome.
We're a bit longer winded on my podcast, so I was like, people probably really appreciate this.
That's what we're going to do here today. So,
Yeah.
super excited because PCOS is just so common now and it is really taking a hold in the fertility space. So, I love what you're doing as well. I know we're going to talk about your podcast and something exciting that you have in the pipeline to support anyone who's dealing with that. Let's dive into it. If you have a client or someone that you're working with, or maybe even just talking with in the DMs, and it seems like PCOS could be something that they're possibly dealing with, or maybe we just want to check into it and rule it out.
Mm.
What are labs that you are ordering that the typical provider is just missing the mark?
Yeah, absolutely. But I think it's really common, especially when we're talking about diagnostically, you get a PCOS diagnosis if you check these boxes. And one of those boxes is high testosterone or high androgens, high what in the medical world we call male hormones very often. And so a lot of times the doctors will pull one lab and it's testosterone. And so if we're looking at that one specific, we need to check this box to see even if we have PCOS that we're dealing with. We want to not just be looking at testosterone. I want to be looking at total testosterone and free testosterone. I want to try and get an idea of not just how much of a burden of testosterone is going on, but how much of that is unbound and quote unquote free. But diagnostically, I want to know how much of that testosterone is free to go around and do what testosterone does in the body. So, not just what's the total burden, but how much is active and floating around. And then there's other androgens. We always hear about testosterone, and I'm sure you speak about this at different points of the podcast, but there are other organs in the body beyond our sex organs that create androgens. And one of those organs is your adrenal glands. And they actually create a specific androgen or male hormone that is largely created I don't want to say in response to stress, but like in cahoots with your body's stress response. And that's DHEAS. It's a sulfated version of DHEA. And that's what I like to test for. There's also DHEA. What we're testing for on most serum or blood tests is DHEAS. And the frustrating thing, I know the question is, what are we looking at? But it's not just even what are we pulling, it's what's lens are we interpreting these labs through? Because many times the lab work is given with reference ranges that are not age or even sometimes gender specific. And that's frustrating when you're just looking at a lab core or a Quest lab requisition or lab results form, and a patient's looking at it and they're like, I'm halfway between the normal range. But that range, if it's a range for all genders, all ages, like we're also looking at 18-year-old boys, not a 30-year-old woman trying to reproduce who may have a higher burden of free testosterone than what would be good and normal in her body that's trying to ovulate. So, in the testosterone, androgen world, I'm looking at those. One thing that I don't look at anymore, at least on serum labs, that I used to spend pretty good amount of money and you pull and you learn and you grow, is DHT, which is a really powerful form of testosterone. And I've just found it always tends to be low, even in people who I think have a really high burden of it, because most of the testosterone that gets turned into this DHT form of testosterone, it's happening within the cells themselves, not like then getting pushed out largely into the blood. A lot of times that conversion's happening in the cell, and then the mechanism of action is happening within the cell. So I don't pull that much anymore. But in addition to the actual androgens themselves, I also want to look at a protein called sex hormone binding globulin. That's something that your liver makes the primary source of. And I often find in women with PCOS, unless they've freshly come off of birth control pills or something that was helping them upregulate this protein, and certain oral contraceptives at that, I often see this level low, and you can think of, I always describe it as like the Mrs. Pac-Man when she's like
Mhm.
floating around and gets to the corner and she eats that like big circle thing, and then all of a sudden she can go around and eat all the ghosts. Sex hormone binding globulin kind of turns Mrs. Pac-Man into, I can go eat the bad guys. She can then go turn off the free testosterone and the other sex hormones, not only androgens, but in a PCOS body, especially when we're talking about somebody struggling to ovulate or ovulating infrequently, that's one area that can be so helpful. So I don't only want to look at the androgens, I also want to look at one of the mechanisms that we turn the androgens off. Now, diagnostically, there's another lab that is now within the international guidelines for diagnosis that I do think is helpful and can be nice to maybe skip an internal intravaginal ultrasound, which is AMH. We talk about it a lot in the fertility landscape, oftentimes in the wrong context, in my opinion. But for PCOS, where we see multiple follicles that contain maturing eggs that kind of get stunted or stopped in the process, they're really good at making this hormone AMH. And we look at it more in the fertility world, oftentimes when people move on to work with reproductive endocrinologists and are looking at advanced reproductive technologies, and they're looking at chances of IVF success. But when we're looking at PCOS, we're actually seeing it as a surrogate marker for how polycystic are your ovaries right now. And that helps us check another box diagnostically, which is, do you have high androgens or signs of that symptomatically? Do you have polycystic ovaries? If we can't, if we can only check one of those, then we're looking at another thing, which is just your cycle regularity, evidence of ovulation, and how frequent that ovulation is happening. And so your doctor may pull testosterone. Your doctor may even be hip on the new AMH guidelines for diagnosis, or looking at it as, let's look at the health of your ovary at this moment. But beyond that, if they're thinking about cycle irregularities, they may also be thinking about prolactin, some of these other sex hormones and hormones that get signaled from your brain to turn on the sex hormones, LH and FSH, and proportions of those things. And once again, it's not even so much, is it getting pulled and am I pulling something different than what the doctor's pulling? And you'll probably really relate to this, Dr. Katie, is, are we looking at it within a context that is relevant? I will hear all the time doctors pulled estrogen and progesterone and they tell the patient they have really low progesterone. But what they're actually saying, or what they should be saying, is, we pulled your labs, and when we pulled them, we know you didn't ovulate yet, because actually your progesterone's so low, it's evidence that ovulation didn't occur. And that doesn't mean ovulation isn't happening. What it means is ovulation wasn't hadn't happened by the time they pulled that lab in any given in the cycle that your labs were pulled in. So a lot of times, man, just contextualizing this information, asking the right questions about people's cycles when these labs were drawn, or giving them the right information about how to get the labs drawn is helpful. Now, that's more the like diagnostic. Can we paint a picture that coincides with what you're telling me in your cycle, what we're seeing symptomatically? The whole other side of the spectrum is your metabolic health, your inflammation and immune responses, and how those things actually trickle down and really impact your fertility, the health of your ovulation, your egg quality, and the health of that follicle that gets left behind and gets turned in the corpus luteum. And so those things that I'm looking at that oftentimes doctors aren't looking at are a fasting insulin to go next to a fasting glucose. They'll often run the glucose in, and maybe not the glucose itself, but as a part of a comprehensive metabolic panel, which glucose is one of the things that gets drawn there. So I'm looking at that and insulin. We're calculating something called an HOMA IR score. I've honestly pared back on, I used to run oral glucose tolerance tests with insulin time points. It's an expensive test for a lot of people. It's an uncomfortable test. And I've found having a little bit more of a zoomed in picture on how extreme the insulin resistance isn't that much more helpful than calculating their HOMA IR based off of fasting labs. And that's a calculation, guys. If you just, we can put a link in the show notes if you have your fasting insulin and glucose to calculators online. But if you Google HOMA IR calculator, HOMA dash IR calculator, and put those numbers in, it's like a way more sensitive way of looking at, am I insulin resistant before you're ever insulin resistant enough to qualify for a pre-diabetes or diabetes categorization of either your glucose or another thing that we pull, which is your A1C. So your doctors are often pulling maybe part of that, but not all of that. And they're often never pulling inflammatory markers. So things like HSCRP, homocysteine, there's a couple interleukins that I like to look at. If there's a family history of cardiovascular disease, we'll do a more thorough lipid panel. We'll look at an inflammatory marker that has to do with heart disease, because we're not only treating the patient's fertility, we're trying to set them up for the healthiest life as a mother. And what if this fertility journey doesn't turn out like maybe they hoped? Maybe we're just setting them up for the healthiest life that they can have with PCOS. So it's a long, I tried to fit it all in very quickly without talking too fast, but big swath of a picture, those are a lot of things that I look at. Vitamin
Yeah,
D, okay, a thorough thyroid panel, I guess I could go on, but those are the major things that I think of that's maybe diagnostic or helpful in the diagnostic, and kind of like what's the underlying thing going on here to be able to then make some really like intentional and individualized interventions that are going to move the needle for a patient.
yeah, no, you broke that down beautifully. And I think that that's going to be so helpful for so many people because I've had clients come to me and they'll share the labs that they've had done with their providers. And it's just like, only little tiny pieces of what you just described are done. So, like just your TSH, not a full thyroid panel, maybe just a testosterone, not the whole androgen picture. And then, even just being a little blown away in terms of we're testing people's A1C in fasting glucose. I've had clients come in, they look picture perfect. And then I look at their fasting insulin and it's, whoa, something is going on
Yeah,
here.
totally.
And the fasting insulin is not a common one that I'm seeing on people's labs that they're sharing from their doctors. So I think that that was, yeah, really, really helpful. And
Can I speak to why that's so important?
sure.
Yeah. So think about the idea of like your fasting glucose, the sugar floating around in your blood. That's normal. And you and I all the time probably see people even in the optimal, like normal's under 100. I want you under 90, hopefully. And maybe that looks good. And your fasting or your hemoglobin A1C looks good, which gives us a view of a 3-month picture of what your blood sugar was probably doing on average. But how much insulin did it take to get that number? That's what we can't answer with those two labs. And understanding, is insulin a main driver of what's going on with your PCOS, is really helpful in terms of the interventions we choose. There are a lot of statistics that say 9 out of 10 women with PCOS probably have insulin resistance. And I would say, in my thousands of patients I've worked with, that sometimes is regardless of body size or even like the expression of their genetics and the phenotype of their disease. It's what does their body, would you say that they look like they have PCOS if you walked by them? I've seen a lot of patients that I would say, no, that doesn't look like a classic PCOS, still have very significant insulin resistance. So getting an answer on how much of an issue is this helps us say, how many of those levers do we need to pull in different interventions, and how far do we pull them? Are you already on something like metformin, but you're really struggling? What are our supplement options we could consider? You've already made some really intentional shifts with your diet, but you don't have any way that you're moving your body really regularly. The beautiful thing about insulin resistance as a main driver of PCOS is there's so many ways to, with lifestyle and habits, treat it and improve it, that aren't just only eat and only exercise. There's more available to you. But if we don't know how high your fasting insulin is to help us say, for one patient, let's say their fasting insulin was 6, that's well within normal range, and some would even argue optimal. But somebody else was 20, and that's still within normal range. But as soon as you throw that number with even a normal glucose into a HOMA IR calculator, you're going to see significant insulin resistance typically. And so that tells me, okay, we need to layer in multiple supports here. But what if we find out you don't really have significant insulin resistance? Then I can do a different thought process in my head about what androgens are sticking out. Are they more stress related, or are they more ovary related? If they're more ovary related, whether you have insulin resistance or not, I'm thinking in my head, your ovaries still play around like you're insulin resistant, and we need to address the mechanisms within the ovary. If the ovaries don't seem like the main driver, then stress, that HPA access, there's other things that I'm digging at: inflammation, digestion, thyroid, what else is really going on. And I think that one piece, like if we could even just get that one lab, it would give us so much more information.
Absolutely. And I think that you described that perfectly. And like you said, there is different drivers of PCOS. And a lot
Absolutely.
of times everyone's just put in this one box of PCOS, but it's a very complex picture. Yeah.
Yeah. And when we're talking about fertility, when we're talking about stakes, I want to have a baby. We need to not just throw one intervention at everyone. Arguably, you shouldn't be doing that with anything ever, but especially in women's health, especially when we're fighting for right diagnoses, especially when it's an uphill battle getting in front of a practitioner that even seems curious or cares. Let's
Mhm.
get in front of the providers that can also run the right diagnostic and root cause supports so that we can make really informed decisions. You'll hear doctors say, we don't need to run insulin because it's not going to change what we're going to do. And that is true for a lot of the doctors out there because their resources are medications, maybe wide swath of the general statement on a dietary recommendation that's often usually not a good one anyway, and then surgery. So knowing how bad your insulin resistance may not change that they're throwing you on metformin, or
Mhm.
that letrozole is the next step in the reproductive support that they have, because that's what they have available to them. And they're not really looking at these complementary, alternative, integrative, or may not even have the bandwidth, if they knew the dietary interventions they could help you with, to sit down and help you with it. It's not what they do. I was just sitting with an OB at the National dietitian conference last week that knows so much about PCOS, but she spends half her life doing surgery.
Yeah.
She doesn't have time to sit with you for an hour and teach you how to make a breakfast that's going to support your hormones. It's just not what she does. And I think sometimes I can maybe come off, oh, doctor, they're so bad. I think oftentimes too, if you just go in with the right perspective of knowing what you're expecting to get from them, maybe you're hoping they're going to run a lot of the labs so it costs you less money, and have a thoughtful conversation about what they could provide for you if you want to move forward with them at any point with what they could do for you. That's helpful information. And then or if there's a particular prescription you're hoping that they can help provide, because I personally don't have that within my scope of practice to provide for you. But if you're just there for that, great. Don't expect them to have gotten a degree in nutrition or gone and done functional medicine training, because that's not what they did. And that's frustrating about our healthcare system. Totally different conversation. Just be clear about what you're hoping to get from them, and then get to the right providers that can help you treat your condition in the way that you're interested in. And because you're listening to this podcast, I imagine you're looking more for Dr. Katie, who's digging into those deeper things and can help you in that way.
Yeah, no, that's a really good point to make there, is knowing what your end goal is, because it is so true. Like they're really educated in one area and in one area only, whereas people like you and I, we look at the whole picture,
Yeah.
and we're gonna go about it a little bit different.
And how different is it your pharmacy background, right? Like you have this incredible background and training in this thing that allows you to come to the functional side and really help people navigate a lot of these conversations, or thoughtfully choose against some of them that may not fit their interests or lifestyle, or but yeah, you don't like, if you want to drive a Kia, don't show up to the Mercedes dealer. If you want to drive a Mercedes, don't show up to the Kia dealer. I don't mean it to be like this major class divide, but like we don't do that in other areas of our lives. But sometimes we do that with doctors, and sometimes that's because we want our insurance to cover it because we're paying so much for insurance. And that's frustrating. But I've had a lot of people waste years of their lives marching down a path that morally they didn't agree with. They felt in their bones like it was the wrong thing, but it's what was available, and they didn't know how to look for anything differently. And I would say if you're feeling that way and you're being marched down a path that way, and you're listening to this, and you're going, we didn't even look at these labs and I have PCOS, maybe put the brakes on and go advocate for a thorough set of labs and re-listen to this again, and then hire someone like Dr. Katie who can help you like tease through that.
Yeah, exactly. So if someone knows that they have PCOS, what are they able to do to decrease the chances of some of, I would say, like the pregnancy complications that can arise when you're already heading into pregnancy with a PCOS diagnosis, like preterm birth, gestational diabetes, all of those things? How would you set someone up to decrease?
Yeah. Oh, so many things. Blood sugar balance. So many of my patients really end up either not getting GD, or they get it and they can manage it with diet and lifestyle because we've gone into pregnancy already working on these things. And pregnancy induces a normal level of insulin resistance that's higher than someone's baseline because of the way that we're trying to make sure baby and placenta get everything they need to support baby's growth and development. Layer that on top of some underlying insulin resistance that maybe wasn't diabetic level yet, then you enter this pregnancy state. And sometimes you draw the short straw and you'd struggle with things like nausea, and you'd eat carbs straight for 3 months until you feel better. Then you've set yourself up in a perfect storm, both by managing symptoms, genetics, just all the things, right? And blood sugar balance, eating enough fiber, eating enough fat, eating enough protein, 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 for blood sugar balance is going to be your best friend on the GD front. And a lot of later complications that often happen in pregnancy happen because of the hyper awareness of risks of GD and risks for baby and risks for bigger babies in labor. And so doctors want to induce sooner. They don't want to let you labor naturally a lot of times when they tell you your baby's way too big for you to have naturally. There's just like a lot of things that happen there. So I think blood sugar balance is one piece. Another piece is maybe not so much what you can change, but rather how you can advocate for you and your baby. And that is having a really robust understanding of your cycle and tracking when you're having sex so that you know when you conceived. Because more than anything, I find PCOS clients tend to have a scenario where they go in for their first ultrasounds and they can't find a heartbeat. And the doctors and the nursing staff and receptionists at the offices are saying, like, come in at this appointed time because based on your last menstrual period, the first day of that, this is how far we expect you to be along. This is when we scan people. And if you ovulate later in your cycle, which many women with PCOS do and can still conceive ovulating later in their cycle, they can have a perfect storm where they go in and baby's growing and developing just as baby needs to, but you're not as far along as they think. And so I have had too many stories of either I've been able to help intervene based on we look at their cycle tracking and when they actually conceived, or stories of like social media people messaging me and being like, my doctor's telling me I had a missed miscarriage or this or that. And I often tell people if you don't have this information, wait longer than you think you need to before you choose to do anything about it. Wait 2 to 3 weeks and go back in for a repeat scan because sometimes they're just wrong. So either have that information and be able to communicate it so that you can get the scans timed well, or skip that first scan altogether and just save yourself the stress. Oftentimes, doctors really want in PCOS patients to get that first scan because it's the best one, they will say, to help calculate your due date from. And there's good reason for why they say that. And there's so much we could go into here, but if you're gonna choose to do that, just be aware of when you know you conceived. Hopefully, you have that information, or you're within a window of a few days at least. And then, as your baby grows and develops, don't let them change the due date on you when you're 7 or 8 months or 9 months pregnant. So that's one thing. Risk of preterm birth is really interesting. I just went to a talk at the National Dietitian Conference last weekend, and it was on nutritional interventions to help reduce the rates of preterm birth. And the one thing that they brought up over and over again was actually fish consumption, omega-3 fatty acids, and that they said, I haven't actually gone and read the research myself, but I'm quoting them, that it's not even just a correlation. It's like really well established in research now that regular fatty fish consumption is like causative in helping stave off early preterm birth. So I'm a real food dietitian. I'd rather you eat the fish. If you can eat the fish, eat the fish. If for some reason you can't, I would say at the very least, make sure you're on a really high quality fish oil with higher amounts of DHA and EPA than most people think that you need. And especially with PCOS, I keep my PCOS mamas on 2,000 milligrams of a fish oil throughout their entire pregnancy until the very end, because it does have some blood thinning effects in case you were to need some sort of surgical intervention. We taper it down towards the end. But fish consumption, fish oil, I would say protein and eating enough sodium is my generic line for helping reduce the risk of preeclampsia. I do put patients on a baby aspirin if they have a family history of preeclampsia and some strong indicators that they have a higher risk of it. So that's something that I consider trying to think what else. The other things, I think I do this with every patient, whether they have PCOS or not, but we're trying to optimize thyroid and vitamin D pre-pregnancy to optimal levels in first trimester pregnancy. A lot of patients with PCOS struggle with thyroid dysfunction at baseline. There's this chicken and egg situation that happens. If you have insulin resistance, you're more likely to have hypothyroidism. If you have hypothyroidism, you're more likely to have insulin resistance. A TSH of above 2.5 is a layer of your risk goes up. And so if we also know, in addition to that, your risk of miscarriage goes up if your TSH is above a certain amount. 2.5 is one of the points in research. And I don't want you sitting at a 3, which is a normal value and not even that much higher than 2.5, because if you look at lab forms for normal levels in first trimester of pregnancy, we usually want you under like 2.2. I would say between 1 and 2.2. I want to get you in that range prior to pregnancy because your thyroid function, your metabolic needs increase so greatly early in pregnancy and things shift so quickly. That is one way we can really lower the risk of early miscarriage, is just optimizing that one lab. Vitamin D, I would say, is another really important one. We're trying to get optimal, not just not deficient or at risk of rickets or something that these levels were based on population wide. We want you optimal for growing a human inside of you that's going to grow bones and an entire nervous system. That's something I'm trying to optimize. And then I guess the last thing I would bring up is going back to the progesterone lab. Many of us get told we have low progesterone. Many of us with PCOS struggle with egg quality related to this androgen dysfunction and some metabolic things that are different in a PCOS ovary. And if we aren't accounting for those things, I see a correlation with, even when we do ovulate, low progesterone production. And so if we have time, I want to work on your natural progesterone production after ovulation while we're trying to conceive. But when you do conceive, I guess the next layer of questions is, in a PCOS person, what labs are you looking at immediately once they're pregnant? And if we haven't seen vitamin D lately, that's one of them. TSH, definitely. I'm looking to confirm the pregnancy with a beta HCG, not qualitative, yes or no, but quantitative. How high is that level? And then the last one is progesterone, because if you have low progesterone, I'm wanting to intervene as early as I can. And I think if we can talk about thyroid, vitamin D, and progesterone ahead of time, we can really decrease the risk of miscarriage that is preventable. Some miscarriages aren't. Many aren't, but in PCOS, there are higher rates of early pregnancy loss. And I think if we can optimize for those, we won't see as high of rates as some of the published statistics are.
Mm-hmm. Yeah, thank you. That's so much good information. And what like came through so clearly in my mind, back to what we were speaking to earlier, is knowing what you want. So if you are to go to, we'll just say, a conventional Western medicine doctor, and their solution is, let's put you on Clomid or Letrozole to get you to ovulate, and then you get pregnant, or if you get pregnant, I should say, and then you're going into pregnancy with all of these things that
We
you just
haven't
brought up
optimized.
that have not been discussed,
We
or
haven't.
probably 9.9 times out of 10, it has not been discussed or addressed before you go into pregnancy. So I just feel like you highlighted so many things that are so valuable and important to think about in terms of big, big, big picture for the health of mom, health of pregnancy, health of baby, even health of baby after they're born.
Generationally. Yeah.
That's like a
Like,
whole nother conversation. But it just really is so important. I think that sometimes we either get so wrapped up in wanting that positive pregnancy test and to get pregnant, or maybe we just don't have the awareness that these are things that should be looked into. And that you have options. And there are so many people like yourself, myself, and just so many others who are educated in there and willing and eager to help you address these things and optimize them ideally before you get
Pre-pregnancy.
pregnant. Yeah.
And I would say one line to that. I have PCOS. My mom has PCOS. My sister has PCOS. I'm pretty sure my mom has PCOS, never officially diagnosed, but all the things, right? I we know that there's some programming that happens in utero for girls in mama's belly and her testosterone levels in pregnancy, helping to tee up that next generation to have PCOS or not, whether you're going to express some of the genetics that come through and all that. Whole other episode. But I think about that. I did a lot of this foundational work while I was pregnant. My first two babies were girls. And I really hope that I gave them enough of a gift in their time inside my belly, and I will give them enough of a gift. And think about this: the changes you make to get pregnant, the healthier the health of your pregnancy is going to extend into your postpartum. And then some of these lifestyle changes you've made, you're going to carry with you, because what we do to help you get pregnant naturally with PCOS is what's going to help you thrive with PCOS. So you're going to have a healthier existence to then continue to teach your children how to manage their health, and not so that they see a mom who's dieting. That's not what I do. They see a mom who loves her body and moves it intentionally and doesn't stand in the mirror looking sideways to see how skinny I am, but I stand at the fridge and say, "Ooh, I really want a piece of yummy, juicy fruit. What type of fruit do I want? It's got so much yummy fiber. Fiber helps me poop." It's like I'm teaching my kids those things now, because when you can peel the layers of the onion back, I was also teaching them those things in utero. They just didn't know it yet. And you get that type of impact. And that's so cool. I think sometimes we get bogged down by all the changes we need to make, and maybe a reframe on the privilege to make the changes because of the gift it's going to give you and your future offspring.
100%. Yeah. And you're just a beautiful example of that. And teaching your kids and your girls, especially even as they're growing up, and not to mention, I'm sure like being aware of their cycles and things like that. Like they're just gonna have so many tools in their tool belt, which is
Yeah.
beautiful.
They're like, "Mommy, you're bleeding again. You didn't get pregnant this month." And I'm like, "You're right, girl. That's the
My
message."
my daughter's is the same exact way.
I
She's
love it.
Yeah, she's 6.5, and like she's known, I feel like she knows more about the female cycle at like age 4 or 5 than
And
most
most women,
women do.
their whole lives.
Yeah,
It's
yeah,
beautiful. What a gift you're giving them.
yeah. So clearly you're a wealth of knowledge. So I'm really excited to have you share about, I don't know if it's still upcoming or if it's ready to let me
Yeah.
know, but your book, How to Get Pregnant with PCOS, because I know I'm gonna get it when it's ready.
Yay. Yeah,
So
yeah,
tell us
yeah.
about it.
This has been a project in the making. It's not released yet. It's coming spring of next year, but I'll send you a link you can put in the show notes where people can sign up for the let us know when the book is coming. You'll only get put on that list. So if you don't want all my other emails, you're just getting tagged for like when the book comes out, send me an email. In probably a month and a half, once we have the cover completely designed, it'll actually just turn into a pre-order link. So the same page, if somebody takes this a week from now, listens this week from now, or 2 months from now, it might be a little different page you can interact with. But so I'll give you a link for that. It is like, it's so long in a good way. It's probably the only book you'll ever need on PCOS because of the statement I just made. To manage PCOS for fertility is really how to manage it. And this will carry you through the PCOS specific things. You might want your own book on what does perimenopause and menopause look like, or this or that. But we're really talking about how to address it, have cycle awareness. I take people through my method where we're looking at nourishment. What is your personal baseline? What does your lab say? What do your symptoms say? What does your cycle say? What does your nutrition say? And then once we have some information about that baseline right now, how do we address it individually. So there's a whole chapter on labs that we blew through about a third of it in a very quick period of time. But it also gives you ranges. And the cool thing is we're doing both kind of US ranges and what the rest of the world looks at. So no matter where you are, it should be helpful for you to look at what's optimal, what's normal, and where you might need to love on different pieces of your body. So that's going to be a wealth of information. I also have an app called the PCOS app. And years ago, in the era of courses, had a $700 course on how to get pregnant with PCOS. And that's all in the app now. And you can pay a low monthly fee for the app, or you can buy an annual subscription, I think, for about $100. And you also get recipes and things. So if you have PCOS, whether you're trying to get pregnant or not, that is a resource. And that's also really cool to check out. And Dr. Katie's coming on our podcast. We have a fertility podcast called Food Freedom Fertility Podcast. I do it with another dietitian, and we interview experts. We also talk about things. It's, as I said earlier, much longer, and we gab out a lot. And Sophia, who I do it with, is hilarious. She should have been a comedian. Thankfully, she chose to be a dietitian and work in the fertility space because we needed the levity she brings to this space. So that's a fun place to hang out with us too. But otherwise, you can find me PCOS Fertility and Nutrition on Instagram. And if you have PCOS and you're trying to get pregnant or someone, come spring 2026, it would be a privilege of my lifetime for you to recommend my book to them, because my goal, this is my like big picture goal. When I was 18, so I'm 39, I got diagnosed with PCOS, and the doctor said to me, it's the number one reason in America why women can't have babies. And there's a lot of problems with everything he said and why and how he said it. But I have an 8-year-old girl and a 6-year-old girl, and like that statistic haunts me, and I want that to change for them. But even more so, I want it to change for you right now listening to this. And I'm hoping this book will be a piece of that story of arming women at home with things they can do today with the food in their kitchen, the sneakers on their feet, the mindfulness and breathing and stress relief, and just all the things you can do, not the things you have to pay a gazillion dollars for, but the things that you can do to love your body into being more fertile.
Love that so much. Yeah, I cannot wait for the book to come out. Like I said, I'm always trying to educate myself more all the time, all things fertility, but especially PCOS, because it is so
Yay.
complex and everyone's
Yeah.
situation is just unique.
Yeah.
I'll definitely be putting it up I have like a little page on my website for recommended
Oh,
products and
cool.
books and things like that.
Love that.
So I'll
I
pop
would
it on
love
there
that.
too. But thank you so much for your wisdom and obviously your passion today, Caitlin. And I'll
Yeah.
be sharing my episode on your podcast as well when it's
Yay.
available. So yeah, it was fun. Are you ready to finally discover why you haven't been able to get or stay pregnant? The Ultimate Fertility Blueprint is a quick, insightful quiz designed to reveal your overall capacity to conceive and help you discover potential root causes and areas to address to improve your fertility so you can finally get and stay pregnant. You'll find the link in the show notes. As a quick reminder and disclaimer, this podcast is for educational purposes only and is not a substitute for medical advice. Always consult your doctor or healthcare provider before starting any new supplement or protocol, especially if you're actively trying to conceive or undergoing treatment.